Welcome to Doctors on Call. I'm Jenna Miller. Chronic pain is a major health problem in the United States and is one of the most weakening effects of arthritis. More than 40 million Americans suffer from some form of arthritis, and many have chronic pain that limits daily activity. Osteoarthritis is by far the most common form of arthritis, affecting about 16 million Americans, while rheumatoid arthritis, which affects about 2.1 million Americans, is the most crippling form of the disease. Arthritis is our topic today on Doctors on Call with Dr. James Anderson.
Presentation of Doctors on Call is made possible in part by an underwriting grant from Gove County Medical Center in Quitter. Healing through caring.
Blue Cross and Blue Shield of Kansas, serving approximately 950,000 Kansans in various programs. A value Kansans trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Russell Regional Hospital, experts, neighbors, friends.
Give us a call at 1-800-337-4788 toll-free with your medical questions about arthritis on Doctors on Call. Our show brings you information which may be useful to you when you see your own physician. Dr. James Anderson received his medical degree from the University of Kansas with his postgraduate training at Wichita area hospitals. He received his internal medicine residency at the University of Kansas and his fellowship training in rheumatology at the University of Missouri at Columbia. Dr. Anderson is board certified in both internal medicine and rheumatology, and he is a founding member of the Arthritis and Rheumatology Clinic of Kansas City and also in Wichita. Dr. Anderson has 30 years of research experience in areas including genetics, immunology, arthritis, and pharmacotherapeutic agents. He is affiliated with Russell Regional Hospital Physicians Specialty Clinic. Again, our phone lines are open at 1-800-337-4788 toll-free if you have any medical questions concerning arthritis. Doctors on Call brings you information which may be helpful when you see your own physician. While the first calls come in, we'll go ahead and start with some of our own questions. Thanks so much for joining us tonight.
You're welcome.
Let's talk about, first of all, what is arthritis?
In general, the term refers to inflammation in a joint. And I think in general usage, we've come to use it to refer to both the inflammatory forms of joint damage and non-inflammatory forms of joint damage. So osteoarthritis is a non-inflammatory type of joint problem, and rheumatoid and lupus and gout and some of the other types of inflammatory arthritis are inflammatory forms.
Who is at risk for arthritis?
We see juvenile arthritis in kids, and we see lupus in young women having their children, and we see osteoarthritis in people who have more birthdays, and everybody is at risk.
So is there something in particular that causes it?
We don't know the cause of most forms of arthritis. Osteoarthritis, the most common form, we think has something to do with the lack of cartilage repair. It may be that minor trauma or major trauma causes some damage to the cartilage, and for factors that include genetics and local measures in the joint, there's a lack of repair of the cartilage itself, which causes the joint to wear out. There's some evidence that tobacco use can cause bacteria in the mouth that may precipitate the development of rheumatoid factor and rheumatoid arthritis. So smoking is one of the risk factors for rheumatoid arthritis.
We talk a lot about prevention on the show. Is there any preventative measures a person can take?
For degenerative or osteoarthritis, maintaining a normal body weight is probably the most important thing to do. For the prevention of rheumatoid, there are several studies looking at screening people who have certain antibodies. There are people with periodontal disease or people who smoke who develop CCP antibodies, which are a predictor of rheumatoid. If someone has CCP antibodies present in their bloodstream at levels greater than 40 international units, and they have no symptoms at all, about half of them will develop rheumatoid arthritis within 3 years. And there's some evidence that hydroxychloroquine or doxycycline may prevent them from developing rheumatoid. So we think we can prevent rheumatoid arthritis now too.
Excellent. Let's talk about some of the symptoms a person might be having.
For osteoarthritis, or the most common form of arthritis, it's usually a weight-bearing joint. Usually there's pain and discomfort later in the day. There's not usually any warmth to the joint, it just hurts. And the more you're on it, the more it hurts. For rheumatoid arthritis or inflammatory forms of arthritis, there's usually stiffness. The stiffness is worse in the morning. If the stiffness in the morning is in the small joints of the hands and feet and lasts an hour or longer, we worry about rheumatoid arthritis.
And when might a person realize I need to get to the doctor?
If you have pain and discomfort that isn't relieved with Tylenol or over-the-counter ibuprofen, usually it's time to see a physician and see what they think.
Mm-hmm. Excellent. What kind of healthcare professionals specialize in arthritis care?
Osteoarthritis, the most common form of arthritis, is seen by orthopedic surgeons. They have special training in injecting and replacing joints. Rheumatoid arthritis is usually the rheumatologist. I think we normally see people with inflammatory forms of arthritis, and the orthopedic surgeons normally see people with the non-inflammatory forms of arthritis. The non-inflammatory forms don't always require an orthopedic surgeon. They can frequently be taken care of by your regular family doctor or primary care provider.
Okay, let's discuss treatment options.
For osteoarthritis, for overweight people, weight loss can be very helpful at reducing pain and discomfort in weight-bearing joints like the hip or knee. Acetaminophen might give temporary relief of pain. In people who aren't taking blood thinners or who don't have ulcers or aren't hypertensive, then anti-inflammatory agents like over-the-counter Aleve or over-the-counter ibuprofen can be very helpful.
Mm-hmm. Now, explain how arthritis is exactly diagnosed.
Usually your physician will do a detailed history and physical exam, and based on the history, stiffness or no stiffness, pain early in the day, pain late in the day, and the physical findings, red swollen joints in the hands and feet or painful large weight-bearing joints, they can get a good idea of whether it's osteoarthritis or rheumatoid. You can follow that up with blood tests, including rheumatoid factor or tests for inflammation. And also x-rays can be very helpful. X-rays are the major part of diagnosing osteoarthritis.
Now, if a person has osteoarthritis or rheumatoid arthritis, can they reverse some of the stuff that's going on inside of them? There's
several treatment options for halting the progress. Mm-hmm. Reversing arthritis is a little more difficult. Once a hip joint or a knee joint has started to lose its cartilage thickness, the progression is pretty inevitable. The cartilage thins and fails to repair itself, and eventually people end up with total joint replacement if they live long enough to see the joint totally damaged. Losing weight is one of the things for osteo. For rheumatoid, the average person who has rheumatoid loses 4 joints per year if they leave it untreated. We have medications, including older medications, that prevent progression of 80% of the different types of inflammatory arthritis. And there are some newer drugs that completely halt the progress of arthritis. Those drugs are expensive and they have side effects, but we have very effective medicines for at least halting the progress of the arthritis. Now, reversing it's a different story. I don't think we have any comfort yet that any of our treatments reverse the progress of any of the types of arthritis.
Mm-hmm. Hopefully soon.
Yep.
How do doctors measure arthritic pain?
We have, in our clinics, we have a visual analog pain scale that we use, and we ask people, rate your pain from 0 to 10, and we also have a scale called a CDI where we count 28 of the most common joints that are affected by rheumatoid, and we mark them as either swollen or tender. And then we can take measurements of the inflammatory proteins, and we can collate all that data, and they have various scores for telling how severe rheumatoid is based on the number of swollen joints, the number of tender joints, the elevation of the inflammatory markers.
Okay, excellent. We want to remind our viewers that we're talking about arthritis tonight with Dr. James Anderson, and we are going to go to the phone lines now. We are going to talk with Sam from Colby. Go ahead, Sam, with your question for Dr. Anderson.
Hi, I am 40 years old and in good shape, fit, and I do have a lot of back trouble. I guess you could say it's more tightness, and I have gone to chiropractors and dry needling I've done, massage, and it still is just, especially my upper back, just so super tight. And I didn't know if I did get tested for and had the rheumatoid arthritis, and what, in addition to what I'm already doing, maybe besides medication, they could do to help me out.
Usual cause of back pain. Usually back pain is osteoarthritis or degenerative arthritis, and frequently it's in the discs. We also worry about osteoporosis in young, slender women or postmenopausal women or women who've taken certain medications for breast cancer or other things. And sometimes it's worth obtaining simple plain x-rays of the back to see how much degenerative arthritis is present in the spine. Some people do well with muscle relaxers. In European studies, there's been success with massage therapy and acupuncture. In this country, we don't get insurance to pay for those things, so it's a little bit less commonly used here, but there are several European studies that suggest massage therapy and acupuncture and yoga and stretching exercises and modalities like heat and cold can be effective for back pain or axial skeletal pain.
Okay, excellent. We are going to go back to the phone lines. We've got another caller waiting to ask a question. This is Jilly on the line from Wichita. Hi, Jilly. Thanks for calling Doctors on Call. You are live on the air.
Hi, Dr. Anderson. This is Julie. And what do you tell patients like me that are in their late 50s, been on every drug on the market, even experimental drugs, with no help whatsoever? What's our next step?
Well, if you've already been through physical therapy with modality treatments and you've been through all of the standard arthritis drugs, there are several research studies that are ongoing. In the Kansas City area, we're doing injections of nerve growth factor. It appears to be very effective for people who are end stage and can't have surgery and aren't responding to any other treatments. I know that the Center for Pharmaceutical Research is doing nerve growth factor subcutaneous injections studies in the Kansas City region. There's some evidence that human growth hormone injected directly into painful joints might be effective. And there's an orthopedic group in Kansas City that's looking at injections of human growth hormone. Those two studies are both experimental, so they're funded by the pharmaceutical companies that make the medication, so there's no cost to you for having those studies.
How do you get into those studies?
How do you get into those studies, she asked?
If you call the Center for Pharmaceutical Research would be the place to call to get into the nerve growth factor and the human growth hormone studies. Okay. There also are some ongoing studies with stem cells. The stem cell research done at the University of Missouri in Kansas City and University of Kansas in Kansas City. They both involve both the orthopedic surgeons and the rheumatologists and the immunologists. Again, these studies shouldn't cost you to get research studies. Pharmaceutical companies will cover the costs of these studies. Now, all three of those are experimental. I don't know that we can tell you how effective they are, but there are places you can look for cutting-edge treatment for arthritis.
But is there anything like that in the Wichita area?
I'm not sure if they're doing the NGF studies in Wichita or not. You might call, if they're doing them, it would be either Via Christi Rheumatology or it would be Heartland Research. They would be the ones. And I think Heartland Research may be doing one of the nerve growth factor studies, but I'm not positive on that.
I could. Do they accept, like, a program in Kansas City on a research program? Do they accept somebody that lives in a different city?
Yes, and they'll pay for your transportation. The human growth hormone study requires some orthopedic procedures, and it may be several trips back and forth.
Okay. Well, thank you very much for your time. I really appreciate all you do.
Thank you so much for calling, Julie. We're going to go to another line now. We've got Teresa on the line from Ellinwood. Hi, Teresa. Go ahead with your question for Dr. James Anderson.
Hi. A couple weeks ago, I had a spell, and they said that I have Bell's palsy, but I've got new symptoms today that I've been wondering about that I haven't had. And one thing is, first off, the side of my face with the Bell's palsy is swelled. My neck is kind of swelled, and now when I swallow, it hurts. And that was a new thing. And also, the side of my head, from the outside of it, it's got sharp pains going to the inside of my head. And it's real bad.
Bell's palsy is more a neurologic than a rheumatologic condition, but there's some evidence that, and this was way out of my field, but I think they're trying antivirals and steroids to treat it. There's some evidence that it might be caused by a viral infection, but it's pain from damage to the nerves, and the neurologist may have some things that could be helpful for treatment.
So she needs to check it with her neurologist.
Check with your family doctor or neurologist for treatment.
Excellent. All right, Sam had mentioned something about osteoporosis in her question. Talk a little bit more about that.
Osteoporosis is thinning of the bones. It can happen in slender Caucasian women more commonly, but it can happen in anyone. A lot of our drugs that we use to treat arthritis make osteoporosis worse, including prednisone and recurrent steroid injections. And we have very effective tests for determining the extent of osteoporosis, and we have very effective treatment for osteoporosis. Some of the treatments are very inexpensive. There are medications that are taken by mouth once a week. They can dramatically reduce the risk of future spine fractures or hip fractures just by taking a pill once a week. Their onset is pretty fast. Some of those reduce the risk of fracture within 6 months of starting to take the medicines. They're also available in shots that you take once every day. There is some shots that you take twice a year, and there are some IV infusions that you do once a year. And all of those medications are extremely effective at preventing the progression of osteoporosis.
And what kind of tests are done in diagnosing osteoporosis?
A bone density test is normally the standard test to see how thin the bones are. If the bones are extremely thin, there are lots of blood tests that are usually done as follow-up to see if there's something else that needs to be treated.
Okay. Now we were talking about surgery and osteoarthritis. When is a patient a candidate for that?
I think there are two main reasons when I would tell someone that they need to see the surgeon. One is they have pain that isn't controlled. You're hurt in the daytime, you hurt at night, you hurt when you're sitting in a chair. If you just can't escape the pain and you're taking more than narcotic analgesics for pain, then it's time to see the surgeons. 80% of people have complete or near complete pain relief. Another 15% get good pain relief. Fewer than 4 or 5% of total joint replacements fail. The other reason to have surgery is you can't do what you need to do day to day. You can't get up off the toilet, you can't get in and out of your car, you can't get your pants on. It's time to go see the surgeons and see what they can do about replacing a joint.
Okie doke. All right, we're going to go back to the phone lines. We've got Mary Jane on the line from Spearville. Hi, Mary Jane. Go ahead with your question for our guest tonight.
Hi, Dr. Anderson. This is Mary Jane from Spearville, and I am going to have a total knee in next month, and I was told I have a little arthritis. And when they do the total knee, is that going to take care of the arthritis?
It will. In general, if you have osteoarthritis in one knee, there's a good chance you have it in the other knee and maybe in other places. But if one single knee is causing you a significant amount of pain and discomfort, usually replacing that knee takes care of the arthritis in the knee.
Oh, good, good. Okay, that's what I needed to know. Thank you.
Thank you so much, Mary Jane. Now, a total knee replacement, what does a patient need to know going into that?
The orthopedic surgeons usually counsel people, but there are some risks. The biggest risk is blood clot formation afterwards, and they do a lot of things to prevent blood clots. It's good to be in excellent shape before you have your knee done, so a lot of the surgeons now are requesting that you lose weight, and they're sending people to physical therapy before the surgery. If you strengthen the muscles in the thigh before your knee surgery, you tend to do better in rehab. No blood clots and lots of physical therapy afterwards, and the orthopedic surgeons try to get you ready for the surgery. They are progressing rapidly with how they do joint surgery, and there are some centers where the joint surgery is done as an outpatient and you go home the same day that you have your total joint replaced. In the Midwest, we're still mostly having people in the hospital for a day or two, and then depending upon the home arrangements, you might be in a rehab hospital for a few days or a week or two to get ready to go back home.
Excellent information. Okay, we're going to go back to the phones. We've got Susan on the line from Goodland. Hello, Susan. Thanks for calling Doctors on Call. You are on the air.
Thank you. My question, I have been on Arimidex because I had breast cancer, and been told that it will be on it for 10 years. And I know I get a bone scan once a year. That was 15, so it's coming up on 4 years. And the bone scan 1 year said that I was, the bones were thinning, and I had one Prolia shot, and since then I haven't needed any. So I guess my question is, I know walking is the best thing for your bones. Is there any other recommendation?
Calcium, and probably no more than 600 milligrams per day is adequate. If you have calcium in your diet, it's even better. Vitamin D supplementation if your vitamin D level is low. Both of those can help your bones absorb more of the calcium. Prolia is an excellent drug, and weight-bearing exercise is one of the mainstays of keeping your bones healthy. If you're upright, there have been several studies that looked at, in animal studies, weight-bearing and impact weight-bearing. Now, I don't think that 90-year-olds should be doing jumping jacks, but there is some evidence that female swimmers who swim to the point of developing osteoporosis have difficulties, but female gymnasts who do the same amount of exercise end up having very strong bones, and it may be because of the impact of landing in gymnastics and the lack of those types of activities in swimming. So upright activity, and it helps a lot. 15 or 20 years ago, the Mayo Clinic used to have people wear weighted backpacks and walk, and the weighted backpacks would put a little extra stimulus on the bones. We don't recommend that much anymore because of the back problems that are associated with arthritis, but weight-bearing activity of any kind is helpful.
And you spoke about the calcium and vitamin D supplements. How do you know you're getting a good quality supplement and not some cheap kind?
I'm not sure I have the perfect answer to that. There are some people who say if you drop the calcium pill in a glass of water and it dissolves quickly, you're probably going to be okay. If you drop the calcium pill in the water and it doesn't dissolve after 15 or 20 minutes, may not be the best calcium supplement in the world. They used to compress the pills too tightly, and you would see the pills in the toilet after you go to the bathroom. That's a sign maybe that they're not being absorbed. They've changed some of the other pills and other medicines, and sometimes you'll see ghosts where the medicine has been absorbed, but the calcium pills, if they're compressed too tightly, they don't get absorbed. They've stopped, I think, since the 80s and 90s. Most of the calcium's pretty well absorbed now.
Okay. Now, we just have a little bit of time left, but we were talking about osteoarthritis and the option of surgery. Is surgery an option for rheumatoid arthritis?
People with rheumatoid develop the same damage to their joints over time that people with osteo develop, and frequently people with rheumatoid will have their hips or knees replaced. There are other procedures that people with rheumatoid end up having that people with osteo don't usually have. Some of the people with rheumatoid will develop deformities of their fingers and their wrists, and they have joint replacements and fusions in the fingers and the wrists that can be very effective. So people with rheumatoid end up with joint surgery too.
Okay, and real quickly, your advice on taking care of our bones?
Calcium, vitamin D, a diet rich in calcium is better than taking the calcium pills if you can do it.
Okay, I think they're telling me that we have another caller on the line waiting to ask a question. We're going to have to go real quick here. I think this is Eileen. Go ahead with your question.
I've had both knees replaced. I have osteoarthritis, and down in the burses, both of my knees on the inside hurt really bad, and on down to the shin part. Now, I have osteoarthritis, and down in the burses,
Feedback, Eileen.
yes.
Okay, keep going. Can you turn your TV down, Eileen?
Yes,
Okay, perfect.
Yes.
Okay, go ahead and continue with your question.
What can I do with this pain? I've had the right hip replaced, both knees replaced, but the bursa and down in the lower part of my legs hurt so bad I can walk just a little ways, but not far.
Some people who have their total joints replaced develop bursitis. The anserine bursa on the inside part of the knee can get very inflamed and irritated. And the orthopedic surgeon who replaced the joints can sometimes inject steroids into the bursa itself, and sometimes that'll give you relief if you're having post-operative knee pain and you had a total joint replacement. So I'd go back to the orthopedic surgeon and ask him if there's some things that he can do to relieve the pain in the lower part of your knee. They sometimes will try some local measures too. They can try heat, and there's some topical anti-inflammatories. Diclofenac gel can be helpful for some types of bursitis, but steroid injections by the orthopedic surgeon who put the joint in would probably be my first recommendation.
Okay, excellent. Thanks so much for being our guest tonight, Dr. James Anderson. For Doctors on Call, I'm Jenna Miller.
Doctors on Call is made possible in part by an underwriting grant from Gove County Medical Center in Quitter. Healing through caring.
Blue Cross and Blue Shield of Kansas, serving approximately 950,000 Kansans in various programs. A value Kansans trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Russell Regional Hospital, experts, neighbors, friends.